Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts, and we'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. As always, there's much for us to discuss. I'm joined today by two of our experts. Dr. Brian Garibaldi is the medical director of the Johns Hopkins Biocontainment Unit and an associate professor at the Johns Hopkins School of Medicine. He'll speak with us today about the treatment of COVID patients. Dr. Bill Moss is executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update about COVID-19 vaccines. I'll now turn to each of our speakers for a brief overview. Brian, first to you. You've been a frontline provider since the earliest days of the pandemic. At this point, you've pretty much seen it all. It feels like we are now might be at a more promising moment, given that cases, deaths, and hospitalizations seem to be declining. What should we be thinking about when we hear about these trends?
So I think we should be encouraged. It's hard to believe, but this is the first time we've been below 80,000 cases since Halloween. It's been a really long 4 months, but I think we have seen cases coming down. I think this is a real phenomenon. With that, we've seen the hospitalizations come down and deaths have started to come down. And I think that's a reflection. It's probably too early for this to be a reflection of the vaccines taking effect widely. So this is a reflection of what we can do when we have, consistent messaging, when people are, taking advice to wear masks and be socially distanced and being responsible in their activities. And that leads to real benefits in terms of the active transmission. I do think we need to remember that even though we should be very happy with these numbers, they're still way, way above where we should be and where we could be if we continue to work together to try to get things under control. We've heard a lot of things in the media over the last week, even about the possibility that some of these variants might make vaccines less effective. And while I think we need to learn more about what the implications of these variants could be for the vaccine effectiveness. It's an important reminder that we need to continue to be vigilant and get things under control. But I think we also need to be hopeful. I'm working here at our hospital. This is the first time in months where the ICU where I'm now currently working is not a dedicated COVID ICU. And I think that's a real reflection of the benefits that we've made over the last several weeks.
Thanks so much, Brian. Nice to hear a little bit of positive news these days. Before I turn to Bill, I want to remind our audience, please submit questions for our experts in the box at the bottom of your screen. Bill, we continue to see this slow but steady increase in the percentage of the population that's been fully vaccinated or received an initial dose. And earlier this week, President Biden mentioned July as a point where vaccines will be potentially much more widely available. Can you talk us through the latest developments?
Yes, thank you, Lainie. And another very busy week around COVID-19 vaccines. And I will start off with a story. And some of our audience may have heard about this, but a 90-year-old woman, Frances Goldman in Seattle, walked 6 miles to get her vaccine. She had struggled with many of the challenges that I know a lot of people in the United States are facing in trying to get an appointment for her vaccination. And finally, after having friends try to help her and spending hours online, she was able to get an appointment, but it was during a snowstorm. Or a snowstorm had just happened in Seattle, and so she put on her snow boots and walked 3 miles to the clinic, got her vaccine, and walked 3 miles back. And it just shows, Lainie, that there's huge demand among some people in our country, as there should be, to get a COVID-19 vaccine. We're still facing issues of hesitancy and skepticism and mistrust in some communities, in some parts of our population, but there are others who can and will do anything to get a vaccine. And so I thought that was an inspiring story. We're now over 73 million doses administered in the United States. I'm sorry, distributed. 58 million doses actually administered. We're up to about 80% of those doses that have been distributed being administered. So we've really seen that gap close. Over 16 million people here in the United States have received 2 doses. So we've fully vaccinated about 5% of the population. And obviously we need to do much, much more in the coming months in order to achieve that. Some of the things that have happened over the past week, obviously we've had this huge winter weather that's really impacted much of the United States, and that has impacted on vaccine delivery. We've seen vaccination sites having to close because of the winter storm. We've seen some of the supply chain have to disrupted, particularly a FedEx facility in Memphis and a UPS facility in Louisville. These resulted in delays in shipments of vaccines around the country. So we have had a setback this past week because of the storm. But hopefully things will start ramping up again. The New York Times did report this morning that there are millions of doses, maybe up to 6 million vaccine doses that are actually housed in states and local locations. These were doses that were either reserved for residents and staff of long-term care facilities or for second doses. And so there is this kind of relatively small pot that people are trying to now tap into that'll increase our doses. But the real increase in doses that we're going to see over the coming months, and this is what President Biden was referring to, we are expecting that Pfizer and Moderna will each provide about 300 million doses. So that's a total of 600 million doses by July. And that was the deadline that President Biden said when these doses would be available. That's obviously enough to vaccinate 300 million Americans, so the vast majority of Americans. But it is, as he noted in his town hall, that it's still going to take some time to get those doses into people. Now, further supplanting or further adding to that supply, we are expecting an emergency use authorization on the Johnson & Johnson vaccine. That's an adenovirus vectored vaccine. There will be a hearing on February 26th, and so we expect that there will be an emergency use authorization in a week or two following that. So that's going to bring an additional supply of vaccine doses to the United States. And then down the line, maybe in a couple months, we'll see the AstraZeneca and Novavax vaccines also receiving emergency use authorization in the United States. So we will, in the coming months, have sufficient number of doses to vaccinate all those who need or want to be vaccinated in the United States. Then the issues are going to change. They're going to be certainly the delivery issues, getting those doses into people, and then dealing with the mistrust and hesitancy and trying to build that confidence in the vaccine. A couple other news stories this week. We're getting evidence that a single dose of the Pfizer messenger RNA vaccine is highly protective. There have been a number of studies. The original phase 3 trial suggested 50% efficacy between the first and second dose, but we're getting reports, including one recent report from healthcare workers in Israel, that there may be higher levels of protection after a single dose. So that's very encouraging news. We also had this week 2 letters published in the New England Journal of Medicine we'd learned about these results before, but basically laboratory studies showing that both the Pfizer and Moderna vaccines had what we call neutralizing activity against the newer variants, particularly the B.1.1.7 variant that was first identified in the United Kingdom, and the B.1.351 variant that was first identified in South Africa. Now, there were lower levels of neutralizing antibodies against that South African variant, but still protective. Now, the real proof of the efficacy of those vaccines are going to be in the real world, and we're going to need to be very vigilant in the United States in sequencing more of the viruses. And I would say particularly when we see COVID-19 in individuals who are either fully vaccinated or previously had confirmed infections. Those are going to be critical to see whether we see disproportionate numbers of the variants in those individuals. We just recently announced that Pfizer will be and BioNTech will be starting trials to evaluate the safety and immunogenicity, the immune responses of their messenger RNA vaccine in pregnant women. This will be a trial that will enroll about 4,000 women, follow the women out through pregnancy to ensure safety, and also follow their infants out for 6 months. This is a multi-country study, but this is really our first, big announcement of a study, a phase 2-3 study in pregnant women. We do know that there are ongoing clinical trials in children 12 to 16 years of age. Pfizer completed enrollment in that trial, and Moderna is still enrolling in that over 12 age group. And then lastly, Lainie, I'll just say that the Biden administration recently announced that they will fulfill the promise for the United States to contribute $4 billion to the global vaccination effort. This was passed originally under the Trump administration, and the Biden administration will continue that. And I'll just end on the note that although we have been focused largely on domestic issues, obviously because of the tragic nature of the pandemic in the United States, the U.S. needs to be a leader in supporting global immunizations. There's gross inequity right now in global vaccine coverage.
Thanks very much, Bill. This is an unusual briefing for us. We got a feel-good story, and both of our experts had some positive things to say about the direction things are heading in. So with that, I'm going to turn to the questions being submitted, and thank you, everyone. I see lots of questions coming in right now. So this first question is a two-part. Brian, I'm going to start with you and then move to Bill. So part one is, can you talk about what we know about the trajectory of the South African variant, either globally or in the US, and maybe what are you seeing clinically right now?
So this is an important question, and one that I think is on everyone's mind. And the short answer is in the US, we're not quite certain how common the South African variant is right now, simply because we're, I think, a little bit still behind the 8 ball in terms of doing genetic sequencing on the viruses that are circulating. So I think Bill's point before is really important. If we start to see, we need to do targeted genomic sequencing of viruses, and we need to understand, particularly if people who have had prior infection or those who have been vaccinated, if we start to see infections in those people, we need to understand if there's a new variant or if it could be one of the South African variants. As Bill mentioned before, there's evidence that in a test tube or in a laboratory, the current vaccines are still effective at neutralizing the South African variant, but are less effective than the viruses that were circulating prior to it. So we don't know how that's going to play out in terms of whether or not people are going to be more likely to be infected. We did see a slightly decreased efficacy of some of the vaccines that were had ongoing trials in South Africa, including the Johnson & Johnson and the AstraZeneca vaccines. But I think what's important to remember is that even though the efficacy was less, they still, at least in the case of the Johnson & Johnson vaccine, prevented severe disease, or as defined by hospitalization and death. And so I think there's still more to learn, but this is an important issue, and I think there's been more attention on the part of the U.S. government, but also on the part of academic universities to try to sequence as many viruses as they possibly can, so we have a better sense of what's actually out there. And we only know about the variants in the areas where we've been doing lots of sequencing. And so there likely are other variants that are out there, and we need to have a better system in place to have surveillance to understand what's happening, not just with the South African variant, but variants we may not even know about yet.
Thanks, Brian. And Bill, to give you the second part of the question, you talked about the South African variant and vaccines in your opening remarks, but is there anything else that we should be thinking about in terms of vaccines, either what's already out there or what might be on the horizon relative to this variant?
Yes, well, I could just highlight what and emphasize some of the points that Brian just made. So it seems like across the board, whether it's in the laboratory or in real life, and as Brian said, a number of the vaccines that aren't yet approved for use or have emergency use authorization in the United States were actually studied in South Africa. I think that the real main point is that those vaccines still seem to protect against severe disease, as Brian said, and that's really a main goal of our vaccination program, reducing hospitalizations and deaths. But there is reduced efficacy against more mild disease, and that is of concern. And so, the main point is people should continue to get vaccinated with the current vaccines. Now, a number of the vaccine manufacturers, including Pfizer, Moderna, Johnson & Johnson, AstraZeneca, are working on kind of updating their vaccines, if you will, and so basically tailoring them to that B.1.351 that was identified in South Africa variant, to try to improve the efficacy of those vaccines against a new variant. But we are going to need to continually monitor the situation. This past week, I think it was, the CDC announced that they are going to be scaling up genomic sequencing, which is really important, going from about 7,000 sequences to about 25,000 sequences a week. But we're still far behind, for example, what the UK is doing, where they're sequencing about 10% of all their cases. So more on the surveillance side to understand what we're dealing with, have some confidence in the current vaccines, particularly against severe disease, and there is ongoing work to update the vaccines in case we need that.
Thanks, Bill. Looks like we're going to be talking about variants for the next couple of minutes. So, Brian, can you talk us through what we know so far about the roughly 7 variants that have been found in the U.S.?
Sure. So, several of them are the ones we've been talking about: the South African variant, the UK variant, the Brazil variant. We don't have enough data from what's happening in the U.S. to understand if the types of disease that people are getting or how sick they get from these variants is any different from the other viruses that have been circulating. There is some data coming out from the UK that the UK variant is associated with not only higher transmissibility, but also slight increase in the severity of disease and the risk of death. The individual risk remains low, but it certainly seems as if the UK variant, at least in the UK experience, has been associated with more severe disease and an increased incidence of death. We haven't seen enough cases or sequenced enough cases here in the US to really understand what the epidemiologic significance is yet. If people are more likely to get ill with these variants, so we would think that that's probably true based on the data coming out of the UK, but we don't have the data on what's happening in the US yet to really know, A, how much is out there right now in terms of these variants, and B, are people having a different experience with COVID illness when they get infected with these variants in the US?
Thanks, Brian. Related question for you. So I know that you think a lot about patient subgroups relative to COVID. And the question is, given the different variants that we know are out there, even if we don't know a whole lot at this point, does that make you concerned about potential limitations when you're looking at different patient subgroups if you don't know what variants are in play?
So that's an important question. We spent a lot of time with our COVID Precision Medicine Center of Excellence trying to understand, what characteristics of individuals might put them at risk for certain outcomes. We have a prediction model that we now have that was developed by a group, including Matt Robinson, who's one of our ID specialists, that's running live in our electronic health record to help people understand what this individual patient's risk of a severe outcome might be. I think we would love to be able to better understand the relationship between the genotype of the virus that somebody gets, but even at some level, the genotype of an individual or the makeup of an individual's immune system that will determine what your inflammatory response might be if you get COVID. I think those are areas of active and ongoing investigation, but we simply don't know yet what that interaction is going to be at the individual level. What it does mean is that we have to make sure that we're continually updating our models. So, the models that we developed back in April may not be applicable to the people who are getting ill right now or the viruses with which they're getting infected. And so I think that's part of our job, is to continually look at the data and to see how these models are performing and to look for new patterns and to make sure that we're not making assumptions based on data that no longer applies. But that's an important point that I think all of us who are doing prediction modeling and taking care of patients are constantly thinking about. Does what I know now apply to the person who's in front of me? And so far, I think that still does apply, but we have to be careful not to lose sight of the fact that things are changing. People who are getting sick could be different, but the virus itself could be different.
Got it. Thanks, Brian. And I have another variant question for you. Do we yet know if there's a variant or variants that originated in the U.S.?
Well, there are variants that have been described. There's one that was described a couple of weeks ago in California. Again, it's hard to know unless we start seeing a lot more of this to know if this was something that originated in a given area or, could have come in from a return traveler for somewhere else. I think it's very likely that there are variants that have originated in the US. And as Bill mentioned, we're going to learn a lot more in the coming weeks as there's been a much greater focus on trying to ramp up testing for these genomic variants to genetically sequence the infections that we're seeing on a much higher level. We're going to start understanding that there probably are variants that are from the US. And many of these variants, are, when you first spot one of these, it could be just because of a particular area where there's been spread of a virus locally for other reasons. It's not necessarily something about the variant that's causing it to spread more. It could very likely be an event or behaviors of individuals in a certain area that could lead to the spread of a certain variant. So just finding a variant itself does not mean that it's going to be associated with worse disease or being more easily transmissible. But we simply don't have enough information yet to really understand that question. But I think in the coming weeks, this is going to be a hot topic and something we're going to hear a lot about.
Thanks, Brian. Bill, a question for you. What are your thoughts about the idea of having more people get vaccinated with a first dose instead of the full 2-dose regimen to try to maximize coverage among the population, especially given what we're beginning to learn about protection afforded by a first dose?
Yeah, this is a really important question, and it's one on which I think, really smart people and with expertise are on kind of both sides. Obviously, what we know best about these vaccines comes from the large phase 3 trials in which participants received 2 doses at very specified time periods, and that's where kind of our best information on the effective efficacy of these vaccines comes from. But it's correct. We are learning more about the potential protective efficacy of a single dose. There's been excitement about the Johnson & Johnson vaccine because it was promoted as a single dose, but that had 72% efficacy, in the United States. And so it looks like with some of the recent evidence, if it holds up, that the protective efficacy of a Pfizer vaccine may be even higher than that after a single dose. So I will commit. So I do think we should be emphasizing single dose into more people, given the efficacy that we're seeing. We don't yet have CDC guidelines on that, so I'll recognize that. But I'm in the camp that getting more first doses into people, and potentially, I think people should get their second dose, but delaying that second dose, I don't think that'll have a big impact. So I'm on the side of getting more first doses into people, and waiting on those second dose. But again, I want to emphasize that that's not what the CDC guidelines are right now.
Got it. Thanks, Bill. This next question takes on an issue that I know is close to your heart right now, which concerns reporting or accurate reporting of vaccination for COVID. So how good should we feel about the reporting of these data in terms of number of folks that have gotten a first dose, number who are fully vaccinated?
Yes, this is a really important question, Lainie, and you and I are wrestling with this just through the work that we're doing on the Johns Hopkins University Coronavirus Resource Center website. I think the point is, I think we've got fairly good dose information on number of doses, administered. But what we really need to know better, and this is where I think there are lapses, is really who's getting vaccinated. We obviously have kind of a phased vaccination effort based on risk factors for severe disease and exposure. And we need to know whether we are getting the vaccines into those people who really need them. And that includes, older adults, that includes minority communities. And as we've talked about before, I think during one of these talks, there was that CDC report looking at the first month of data where race ethnicity was missing from half the reports. So we need to do much better in terms of having standardized data with federal standards. So the states are all reporting the data that we need so that we can better understand who's being vaccinated and whether or not we're really meeting our goals. So I think this is critically important and an area of improvement.
Thanks, Bill. Another question for you. Should someone who continues to test positive for COVID or is told that they have COVID antibodies still be getting vaccinated? And should they be pursuing the full 2-dose course or just a single dose?
Yeah, so the current guidelines are that even if someone has had documented COVID-19, they should still receive the 2 doses of the vaccine. And just a couple points on that. One is because there is some variation in the antibody response after natural infection. We think that people who've had more severe disease probably have a stronger immune response than people who've had asymptomatic or mild disease, but we're still learning about that. And so we know with a lot of confidence the protection that's conferred by the vaccine. And so it is prudent, I think, for people even who've had documented COVID-19 to be vaccinated. The antibody tests that are commonly used, kind of just to measure that are done commonly, aren't measuring actually what we call neutralizing antibodies. So it's not they're not the best surrogate of protection. I think they provide some correlation to protection. Now, I think there is room for debate about whether someone who's had documented COVID-19 and has documentation of the presence of antibodies, whether a single dose of the vaccine would be reasonable and protective. So I think there is room for discussion on that, and I think we may see our policy evolve over time on that as we learn more.
Thanks so much, Bill. Well, we are coming up quick on 12:30, so I'm going to wrap up. I'd like to thank Brian Garibaldi and Bill Moss for joining me today and give a big thank you to everyone who joined us in the audience, and especially to those of you who submitted questions for our experts to answer. This briefing will be archived and available on coronavirus.jhu.edu. As a reminder, we offer these regular 30-minute briefings on Fridays at 12 p.m. And in each briefing, we'll focus on what you need to know right now about the COVID-19 pandemic, and we'll have live Q&A with our experts. I'll look forward to seeing you at our next 30-minute briefing. Until then, thanks and stay safe.